Carol Worthman is the Samuel Candler Dobbs Chair of the Emory Department of Anthropology, where she also directs the Laboratory for Comparative Human Biology. After her undergraduate degree in biology and botany from Pomona College, she earned her PhD in biological anthropology at Harvard, having also studied endocrinology at UC San Diego and neuroscience at MIT. She joined the anthropology faculty at Emory in 1986 and has helped to build its biocultural focus and establish its leadership in the field. Professor Worthman takes a biocultural approach to interdisciplinary research on human development, reproductive ecology, and biocultural bases of mental and physical health. She has conducted cross-cultural, ethnographic, and biosocial research in 12 countries, including Kenya, Tibet, Nepal, Egypt, Japan, Papua New Guinea, and South Africa, as well as in rural, urban, and semi-urban areas of the United States. For the past 20 years, she's collaborated in the Great Smoky Mountains Study, a longitudinal population-based epidemiological project in North Carolina. She's the author of over 130 publications, articles, working papers, invited reviews, abstracts, book chapters, and an edited volume. And her topic today is there a mental health equivalent to clean water? Carol?
Well, Holly, thank you for that lovely introduction, and thank you, Gray, and the rest of you for an invitation to talk with you today. Actually, weirdly, I find Zoom a rather more intimate way to communicate with people because you're all in the front row, even those of you who have blanked out your screen. I have more of a sense of your presence. And I'm really excited to talk with you today, and hopefully we'll have some discussion about a question that has occupied me for a long time, and which the present moment has really brought me to more insights. So I'll share the screen and talk about, is there a mental health equivalent of clean water? So first, to explain what I mean by this question, why clean water? Oops. It's frozen my, let's see what's happened here. Sorry guys, it's frozen my mouse. Okay, I'll use that. So water is essential for life, but clean water is preventive. It's actively protective of health, and it benefits everyone. So it's a public insurance with daily benefits. And therefore it's considered essential and also a human right. So providers of clean water are considered to have moral obligations and are treated as public servants. So all we have to do is think about Flint, Michigan to think about the logics that go behind that. So in that context, ideally, everyone has access and everyone contributes. I said this specifically rather than pays, because clean water should be affordable. So how is this relevant to mental health? Well, mental health also may be considered a subject for a public good. But rather than something like water, what's essential is, yes, a healthy brain that requires huge amounts of oxygen and glucose, but the mind requires social goods. It requires cultural goods. And this makes it distinct from some of the other logics that drive public health and biomedicine. So what I'm going to talk about in the following 45 minutes or so is why we don't have answers to this question, and why now is a moment for really long needed change in our approaches to health, starting from the health sciences. So those of us, I'm going to say, in virtually any discipline have a stake in this project, and I'm going to talk about some of the promising directions for change and action. So first, a bit of background. The last 150 years have seen tremendous gains in health through moves in biomedicine and public health, with dramatic increases in life expectancy. And these were attributable to distinct innovations that were based on, first, sanitation, so latrines and clean water, vaccines, prenatal care, nutrition, and pharmaceuticals, particularly antibiotics. And notice that the first 4 of these are all preventive. So we see tremendous gains, particularly in infectious diseases and in the first 5 years of life. But what has lagged behind was particularly mental health. But mental health, along with some other things, was really a product of the paradox of success. That is, as we became more and more effective at applying the existing tools that we had, this left a residue of health challenges that were less and less amenable to the tools that we were using. And so some of these are the paradox of unmasking, that is, the removal of infectious diseases left a residue of chronic diseases that were always there, but which the existing tools were less effective. But there is also the issue of local biology, that is, the assumption of a modal human body worked really well. But then the efficacy of that began to slow down in the face of the real biological diversity and functional diversity that exists in humans based on the complexity of the different social and material environments in which we live. And a third paradox was socialization, that actually these more technological, pragmatic solutions were less effective for the soft side of things that involved health issues that were based on behavioral, social factors. And third, and this of course, COVID is a dramatic example of this, were the re-emerging diseases. We had the idea that we would get rid of diseases. Well, hello, all the species that were involved were in a struggle for life, right? So they're fighting back, and the depredations on the environment have led to new pathways that are exposing all creatures, including us, to new forms of danger. And then lastly is not just inequality, but what we've called savage inequality, which is, as I'll explain later, inequality, perceived inequality is not so good for mental health. And inequality has long been with us, but what has happened is a dramatic escalation in the, both the reality and the perception of inequality. So one of the big advances that helped us move away from purely looking at the quantity of life, numbers of years that people lived, but to look more at the quality of life, was the development by Murray and others at Harvard in conjunction with WHO of the concept of the burden of disease. So there are lots of caveats about this, and you can imagine that most of these are estimates. But what the attempt here is to look at the years of life that are lost, along with the years of life that are lived with disability due to any specific disorder. And so this, the metric that came out of this was disability adjusted life years. That gives you a sense of the loss to not just life, but quality of life, so DALYs. And using this DALY metric produced a different picture of what was going on and was particularly congenial for looking at the epidemiologic transition that was going on. So what I'm showing you here is from WHO, is the percent of national DALYs, disability adjusted life years, that are due to non-communicable diseases. So I was talking about that epidemiologic transition going from infectious to chronic disease, non-communicable disease. And you can see here that there are countries, and you'll notice who they are, that where greater than 85% of the burden of disease is due to chronic diseases. But you'll also notice with the countries in reds and oranges that has also been an emerging inequality in the rates of the epidemiologic transition, where there are a number of places where infectious disease is still a huge issue. So the DALY approach in particular revealed something that was really surprising for many, but welcome for those of us concerned about mental health, because it revealed the real burden of mental and behavioral disorders. So what I'm showing you here on the left, it's 1990, on the right, it's 2010. The various categories of diseases, and circled in yellow and the blue are the mental and behavioral disorders. It depends on how you calculate it, but basically among the chronic diseases, mental and behavioral disorders right now account for about 28% of the burden and 14% of the global burden of DALYs overall. So this startling revelation really put some fuel into drawing attention to the need to address mental health more effectively. Notice, by the way, that there has been no change in, and that was the point of this article actually, was there was no change over the last 20 years in the burden of disease due to the mental and behavioral disorders. So I'm an anthropologist, and so what I'm going to talk about now are really the cultural logics that lie behind public health and biomedicine, and which has been studied in medical anthropology a lot, that may help us to understand why we've had success in some areas and why we've lagged so badly in mental health. And I'm just going to draw your attention to, although DALYs are very useful, they still focuses on disorders and dis-ease rather than on the notion of wellness. And I'm going to argue that an attention to mental health also draws us to thinking about wellness. But what are the cultural logics? Well, the big one, of course, is the mind-body divide, the old Cartesian dualism, the old Cartesian dualism that separates the two. In addition, we have materialism and causality. That is, the sciences particularly, that's a lot of what I do, is focused on what we can measure, on mainly material things, and we're interested in cause, what makes things work, so that we can try to get at ways to intervene. Another huge metaphor is the notion of the body as a machine. With the body as a machine, the machine can be fixed. Furthermore, fixing a machine requires technicians and who are specialized, and this raises the opportunity for monetization. The body can become a commodity, and biomedicine, at least as it's practiced in the US and as has been widely discussed recently, the body is really is the commodity, and it's an industry. But another logic is the notion of, that's related to body as machine, is that the body is hardware and the psychology is software. So the mind is immaterial. It's not something that we can get at with these other material things, and that makes it less fixable. We can't get our hands on it. And then the last thing, and this is particularly powerful in the US, is individualism. My mind is mine, and my mind is my problem. It's not a public problem. It's not something for everybody to be concerned about. So I thought to illustrate this, because this is kind of pretty abstract, I would use an example that actually comes from biomedicine and basic science research, but really shows you how existing powerful metaphors and logics can be very useful, but actually can stand in the way of medical advances. And many of you will be aware of this in terms of the big discovery of the human microbiome. I don't know about the rest of you, but it was about 15 years ago that I was preparing a lecture for my human biology class on the guts, and I started reading this literature, early literature in the microbiome, and it's like, holy moly, right? I mean, there's all this life in us. You know, we've got over 2 pounds of critters in our intestines, if we're just looking at the intestines, and the microbiome, of course, is all over our surfaces. So we are comprised of over 500 species in our guts alone that contribute enormously to our genetic complement and diversity. Each of us has a very specific microbiotic profile, and we've learned that these symbionts play really important roles in metabolic and immune function, as well as exerting psychobehavioral effects. So why didn't we notice this before? Well, there's those powerful logics that one is important germ theory that said, hey, bugs are bad for us. Bugs exist and they're bad for us. They should be eliminated. The second is sanitation practices that are based on the notion that excreta, and the reality that excreta are filthy and that they're dangerous. And lastly is the notion of the body as a contained unit. Again, this relates to individualism, machine, and so forth. So I am my body. I'm not anybody else, right? But the revelation here was that there are a whole bunch of organisms that we live with, that we rely on, and they are good guys that provide all kinds of health benefits. And furthermore, I actually am we. And this actually led to the director of NIH to put this on his blog, which was a dramatic reversal of our attitudes to bacteria. Okay, so another impediment besides these cultural logics to mental health and its treatment is the issue of stigma. In virtually every society, mental health, almost by definition, involves cognitive, emotional, and behavioral impairments that the person should, but is not able to control. This raises challenges to agency. There are moral transgressions, threat and contagion, and social costs that take very specific cultural forms, but essentially mean that mental health is frequently, mental illness is an object of shame, something to conceal, and is a social problem that is generated from an individual disorder. So with all of this background, let's fast forward to our present moment. And I think I want to argue why this is a particularly opportune moment to realize some really important changes. So COVID, as we have all been forced to witness, has wreaked widespread havoc and enormous costs. And we can see that it eludes our existing approaches and it exploits existing conditions in societies, populations, our beliefs, our ways of doing things. So we're startled to realize that our sciences did not include knowledge about the effects on virtually every sector when best practices would be taken to scale. So as the pandemic unfolds, it has exposed fault lines in economic, educational, political, ecological, and medical arenas. And it has made us keenly aware that health is not something we can put in a little box, that health is really embedded in social context. And what we've seen then is that issues that we knew existed have been magnified by the impact of COVID, such that we really, really can't ignore them anymore. So disparities in resource distribution, in infrastructure, in quality of life, and life opportunities, the acute and cumulative effects of disparities are coming home to roost, both in terms of survival itself and in terms of the social and mental effects on people. So these are data from this month. You've seen, I'm sure, many such graphics that show how these disparities have played out, such that by the middle of this month, 1 in 1,000 African Americans had died of COVID. So that's shocking enough, right? But we can put this in context by looking at the relative risk, the relative probability that African Americans and other minorities would die in relation to whites when control for population structure. That's what I'm showing you here, that African Americans have experienced over 3-fold the probability of dying, and other minorities not that differently compared to whites. So that's been really shocking, but we knew a lot of this stuff before, right? It's just disembedding what we know to be true. It also, we should bring to mind a report from 5 years ago by Case and Deaton that actually pointed out that it wasn't just the marginalized, that it was actually the putative and empowered individuals, the entitled individuals who were also suffering. And this is now famous Case and Deaton study of 2015, showing that by contrast to the systematic reductions in mortality rates in midlife among males in wealthy countries, that the US was going in the opposite direction and had been doing so for the last 20 years. Now, this trend had been fueled by mental health problems. Okay? And these included overdose, and we've heard a lot about this too, overdoses, suicides, chronic liver diseases related to alcoholism, such that cumulatively all of these sources of mortality hit 78 per 100,000 individuals. So right now the US is running at 60 per 100,000 for COVID. It's going to be higher because that's, we haven't ended with the epidemic yet, but it gives you a sense of the scale. And yet it took us how long to notice this, right? Because we're so busy not noticing a lot of these health issues. So in this regard, there are 2 really valuable constructs, I think, for us to draw from that come from social sciences and epidemiology. The first of these, oh, and by the way, I use that word pain here, right? Because certainly for anthropologists, it was completely obvious that we're not talking about physical pain here, right? So all those painkillers were, yes, were related to pain, but the pain was really an existential pain that was linked to the corrosive effects of systemic racism, structural faults, with pervading economic, institutional, political, environmental, and health sectors. And the source of the pain is societal then, linked to enshrined notions of hard work, dignity, and self-worth, with factories and farms and owning a home, earning a living, supporting a family, building a better life for the kids. Well, as many economists and sociologists by now have pointed out, that has not been true for about 40 years for whites, but it has not been true for much longer for African Americans. So the terms that are relevant here are first, that have been around for over 40 or 50 years, are structural violence for one. And structural violence are the avoidable constraints that a society places on a group of people that impairs their meeting their basic needs and realizing a quality of life that would be otherwise attainable in that society. And so that's, I'm re-displaying that graphic below because these outcomes are arguably the result of structural violence. And the recognition of that in such a flagrant manner has really been a lot of what has fueled Black Lives Matter, not only among the African American community, because of the callous disregard for human life, the flagrant use of state violence, and the misrepresentation of reality. But this movement has pulled in many others and around the world because increasing numbers of individuals feel the heels of structural violence. So a betrayal of trust, a betrayal of shared ideals, which are not realizable. A second term that can be relevant here, and which comes in this case from epidemiology and psychiatry in relation to the military services, is the notion of moral injury. And actually Simon Wesley and his colleagues have done really heroic work to demonstrate this as a phenomenon and actually the proximal pathways by which moral injury results in mental health injury. And moral injury is the psychological distress that results from actions or the lack thereof that violate someone's deeply held moral or ethical code. So the person feels responsible, is held by society to be responsible, to hew to a particular code of ethics, but is unable or not allowed to realize that code. And of course, where moral injury has been most in the forefront during COVID has been in the area of healthcare providers, where again, we've seen the healthcare industry has actually not provided its workers with the basic essentials to do what they need to do, resulting in moral injury and widespread issues with mental health that are likely going to play on for a long time because the healthcare providers already have escalating rates of suicide before COVID, issues of substance use and abuse and so forth, burnout, leaving the profession and so forth. And I thought it would be useful to look at some real people who have been victims of moral injury. You've already seen that with the Black Lives Matter and the outrage that relates to that. But the Times had it spread on healthcare workers in North Italy, where spectacularly the system failed and so many people had to be allowed to die for lack of resources. And so I'm just going to show you some of these people: physicians, nurses, emergency care providers, triage people. These dedicated and selfless carers are, we could say, part of the solution, yes, but they're really cleaning up our mess. right? The solution to COVID pandemic is really a societal one, and the prevention of future such events or making our response to them better is really a societal or even global matter. So these guys can't prevent it in the first place, but we can. So this is partly why I'm arguing that the effects of the pandemic in general and on mental health in particular point to their cultural roots and really present us with acute, time-sensitive opportunities to address them. So new threats such as COVID require novel strategies, and the pandemic is teaching us about what needs to be done. So I'm going to highlight 3 lessons. The first, as I've been emphasizing, now is the time to evaluate and rebuild our approach to health science. Those of you at Emory may recognize this as the basic drawing plans for our latest health science building. So public health and biomedical research and intervention have focused on too narrow a set of factors known to affect health. And so the massive societal and mental health toll of COVID reflects this. So I'm saying this is a call to action. Pull out your pens and tablets, everybody, because this is a challenge for all of us. I'm arguing that furthermore, that mental health should serve as a focus for our efforts precisely because of the lack of our success in the past. These great public health measures, such as sanitation and provision of clean water as social goods, have saved and improved those countless lives, while mental health equivalent of clean water has remained elusive. Let's tackle that. Second, these new approaches must reconnect health to the existential and societal conditions that shape it. And this is going to require a reworking of cultural logics. And I've talked about the stark differences in morbidity and mortality between and within populations that clearly highlight the physical and mental toll of flagrant inequality, systemic discrimination and marginalization, and concomitant erosion for public goods, of support for public goods, along with the vested forces that produce these corrosive conditions. So the domino effects of the present pandemic have demonstrated the close interconnections of health with economy, with education, politics, environment, virtually everything else. So mental health stands at the nexus of these forces and requires that we integrate from many fields. And from here, the social sciences have already been on the scene. They can be on the scene more, as can the humanities, to provide perspectives that broaden the lens and open us for critical inquiry. So I'm arguing that the call for no health without mental health offers a great starting point for the arduous but exciting process to change not only policy, practice, and values, but also health science itself. So in 2007, there was a piece entitled No Health Without Mental Health in an influential Lancet series on global mental health. And the authors went back to that DALY understanding of the global burden of mental health and behavior disorders. Just to make things a little more real, at the bottom, what I'm showing you is one of the more effective metrics. This is from Paul Bolton, that are used in global settings to try to help people to articulate the burdens of the daily and mental health problems they face. And this group of mainly psychiatrists, epidemiologists argued that there's no health without mental health, with a whole lot of evidence. And so the first of these was that actually about a third of clinically reported symptoms remain medically unexplained. And tellingly, the biggest of these is pain. Next, there's fatigue, and then there's dizziness. Secondly, the non-communicable diseases and their treatments are closely tied to mental health risks. And so cardiovascular disease has been, and cardiac incidents have been repeatedly associated with depression particularly. But depression in turn has also been associated with risk for diabetes. And furthermore, the treatments for specific cancers, the inflammatories particularly, have been linked directly to depression by Greg Miller and Chuck Raison here at Emory. Furthermore, communicable diseases and their treatment also are linked in to mental illness and illness risk. So the outbreaks of TB that preoccupied people in the 90s and early 2000s were deeply linked to untreated mental illness. Less well recognized, but emerging literature shows the linkage between post-traumatic stress disorder and risk for HIV/AIDS, controlling for everything else. But furthermore, taking antimalarials actually has risks for cognitive function, and their routine use is related to impaired cognitive development in kids. And then lastly are injuries and accidents. For example, substance use and abuse has been linked to accidents. We know this well. Violence is linked to, exposure to violence is linked to PTSD and depression. So this review really pulled together a giant body of literature that really shows us how mental health can't be stuck in a box. It's really tied in with everything else. So that's our second lesson. The third lesson is that actually we already know a lot of what we need to know to tackle some of this stuff. And what we really need to do is take our knowledge out of the box of the academy and our knowledge bases and bring them more effectively into action. How we do this ethically is a huge issue, but we've got to take this on. And how do we do it? I'm just going to suggest two areas. There's lots that we could talk about, but there are two levers that we know that we can push for the social production of health. One is inequity reduction. So the rise of income inequality has been much discussed and heavily documented by people like Piketty, and that's what I'm showing you here. This is his most recent graph from his 2020 book, showing the steep increase in share of income among the top 10% in a range of countries around the world. But more than this, evidence per se is the popular and shared perception of wealth inequality and maldistribution. This is, some epidemiologists and social scientists have argued that the perception as well as the reality really matters. And one of the key people who's pushed this argument is Richard Wilkinson in the UK, and in general, folks in the UK are very sensitive to issues of class and relative status. In the US, we pretend that class doesn't exist. And so here's he actually pulled this from an early simple analysis that he did, showing an apparent relationship between income inequality and an index of health and social problems. And as usual, and this happens all the time, the US is an outlier largely by virtue of its great wealth, its population size, its availability of data, the massive health expenditures that we put out, and our relatively poor health outcomes. But an old finding is actually worth paying attention to, which is that this is not that simple. There's lots we could take apart on this, but money is also not all there is to it. So this is showing you life expectancy at birth by gross domestic product. It's old, it's 20 years old, from 1999, and showing you that after about $2,500 in 1999, about $4,000 now, the relationship between GDP and life expectancy flattens out. And so what then do we do? What really matters to reduce inequality within that? This is just income. So what do we do about equality reductions? Because you can see that actually life expectancy in Costa Rica at that time was about the same as it was in the US. But we would have to dig deeper to say, well, what are the disparities within that? How would we address that? How would we advance life expectancy? And I'm going to cut through a huge literature just to say we have a whole armamentarium of proven measures that we can do to reduce disparity. One is early childhood development and nutrition interventions, universal health coverage, universal access to quality education, cash transfers to poor families. This even helps for mental health, investing in rural infrastructure, and tax reform. So the second arena that we can work on, we've all been so focused on risk, but there's an emerging literature on resilience and a building sense that we really need to work on not just reducing risk, but building resilience. And that the resilience resides not just in individuals. It's not an individual project, that it's a matter of social goods and it's a social project. And so it's from the individual all the way up to the societal level. And so what is involved for resilience? Again, big literature on this, but meaning, belonging, purpose in life, dignity, hope. And we also know some really powerful bases for this. One of which comes out every time is education. Another is security. A sense of security even will do, much less the reality of it. And then finally, health. And so I'm going to end with a story about resilience, because this is an area, as I said, that needs a lot of work. And I'm going to show you its power, however, in the context of work that we've been doing over the last 20 years in Nepal. So as some of you may know, Nepal experienced a civil war that broke out in 1996, raged for over 10 years. And in the post-war period, we were invited to go by UNICEF. Brandon Court and I went in with colleagues in Nepal to do a multi-sided case control study of matched ex-child soldiers and their peers. And what we found, unsurprisingly, was that exposure to trauma and the extent of the trauma was related to mental health outcomes, PTSD, depression, suicidality, but that these were moderated by social factors such as gender, age, family wealth, and community composition. So we did a series of interventions, and about 5 years ago went back to follow up and see how the young people were doing. And in the process, I'm a biological anthropologist, as you heard, and so I wanted to make use of a new technique for using immune activation arrays as a way of summarizing, indexing the burden of stress on the body. In addition, we wound up using a measure of resilience I thought was pretty crappy, actually. It was based on a US measure, but actually we used it because our field staff were saying that kids were talking in terms, the ones who were doing a little better, were talking in terms of that they could make decisions, that they had a plan for their life, that they thought their life was worthwhile, that it was meaningful, that they had something to do. So we included that measure of resilience. And to our astonishment, this proved extremely powerful. And so, as I said, we applied that immune indicator of stress to look at the impact of past experience, past adversities on how kids were doing now. And yes, we found that ex-child soldiers had elevated indicators of stress. So what I'm showing you here on the right, we're using civilians as the comparison group, right? And showing that child soldiers have elevated stress index compared to their civilian peers, controls. And then on the far right, we're looking at just the subset of ex-child soldiers who had PTSD and were extremely low on resilience. We sort of looked at that and said, oh my gosh, what's going on here? So then we went on to just look at the ex-child soldiers with PTSD and the relationship of their self-reported resilience to the physical impact of the trauma that they had experienced in the present, so past experience in the present. And I mean, this was stunning to us, a clear linear relationship where kids with low resilience with PTSD had very high indicators of stress, whereas those who had PTSD but very high resilience showed virtually the same, that is very low indicators of stress comparable to their civilian peers. So where did this resilience come from? What does this really mean? This is something that we're really focused on right now. But I want to give you a sense of this then, that we can do things about mental health, but those things involve different efforts than antibiotics and vaccine. So to end, this question of, is there a mental health equivalent of clean water? I've been saying we don't know the answer because we haven't really been looking properly. We haven't been looking in the right places, and our assumptions, cultural logics, and power dynamics have been in the way. And so, but the neglect of mental health has come at a cost to better addressing health writ large. The ravages of COVID present us with a teachable moment that we must seize to realize real change in health sciences and in society. We have plenty of evidence to work from, but we must forge new, broader ways to ask critical questions and undertake the work to make knowledge actionable from the local up through the global levels. And so this is going to involve arduous work of reworking cultural logics, power and resource allocation, structural reorganization, meaning making. We all have been looking at this. We know what's involved. So lastly, I would say that if we do realize the goal of no health without mental health, we will indeed come closer to achieving simply health. Marilyn.
Yes, hello. Thank you very much. I enjoyed your presentation. There's lots to think about. And one note I wrote down because I thought I got it, but I wasn't quite sure, was in your discussion of mortality, ages 45 to 54, you mentioned poisonings. And to my mind, that was tobacco and alcohol and drugs. Is that?
No, yeah, there is, but most of the poisonings that are due to alcohol are attributed, come under cirrhosis of the liver because you can find a body part that is
Okay.
messed up. But the frank alcohol overload that we see sometimes, particularly in undergrads or young people, that would count as a poisoning. You're right. So it isn't just opioids, it's all substances of abuse.
Does it include opioids though?
Oh yeah, no, that's, yeah. Isn't that interesting? Yes.
Yeah, because I always
Poisoning.
think of poisonings being, and smoking and various other things that one does to oneself, but I think that just drugs in general are a problem.
Yes.
Okay, thank you.
Yeah, but it could also include lead poisoning from Flint, Michigan.
Oh, okay, okay, which you don't voluntarily take on unless you just
No.
move to Flint. Okay.
No. So we want to be careful about that. Well, and I'm not so sure that those opioid overdoses are voluntary, right? But we know that the lead poisoning.
Okay, true enough. It's hard when it's poisonings is a big category.
Absolutely, and that's where I think that's what I'm talking about, of really getting the epidemiologists and social scientists and humanists who are used to doing textual analysis and thinking about what does this word mean, really
Right.
getting together to try to unpack some of this stuff. I hope it came through that I'm not bashing the past. I'm sort of saying this is a great opportunity for us to do better and different.
Thank you.
Yeah, thank you. Denise?
Hi, I'd like to thank you. That was so wonderful in reframing how I kind of approach the thoughts about this. So I am a physician as well, an OBGYN.
Oh, well.
And
Thank you for what you do. It's a tough.
yeah, it was hard. But as you ended, it immediately occurred to me that much of how we framed our response to the opioid epidemic and even treatment of mental health is squarely in the space about what the doctors can do or what the social workers can do, rather than thinking about how can we create interventions that provide this resilience. Right, so in OB, we had a new model for prenatal care centering pregnancy. And the idea was ultimately that we could reduce preterm delivery through this group prenatal health. So all the women have a group, they meet together, they discuss problems, they talk about solutions in the context of, you know, what I did when I had my UTI, or, you know, so it's a mutual aid society, and the group all deliver around the same time so they can continue to support each other afterwards. And I thought of that, that's a great model. We could roll that out into, like, let's tackle diabetes through this kind of mutual support.
Right.
That also seems to me the kind of model you could use in the context of mental health, but not because most of the mental health that we have now in groups is really through this sort of anonymous process where people sit together in the room, but then when they leave, they don't have that as support that stays with them out of the community and into their lives. The same thing is true of drug treatment particularly, because most of the time the people, when they leave and go out in the community, their problem is their friends were the people who helped get them into drugs, rather than finding a set space where people don't use drugs. That's incredibly true for cocaine, because if you go back to hang out with your friends and they're all using, you're going to use too. Right? So I feel like you hit upon a wonderful way to begin to think about different kinds of interventions we can bring to how we view mental health, more in terms of how can we create group support settings and aid in resilience, as opposed to, well, let's put people together, cure them, and then send them on their way.
Right, right. No, that's great. Thank you for that. I look forward to everybody doing this, right? I mean, this is our social work, right? And that's the other thing, is not relegating health to a small number of specialists. I mean, with all due respect to doctors and healthcare providers, but that this is everybody's, the daily production of health. We've even seen that in COVID, where there's stuff online encouraging you to be nice to people in your interactions online, right? Because as a mental health or health thing, and it's like, hello, yes, that could be good.
Yeah, I think we've seen that in communities now, who even just people who organize to deal with gang violence, and then begin to interact with people in the community and sort of deal with the things that led them to become gang members, or, you know, mothers against drunk driving, who are trying to create structures within communities that are designed to bring this resilience to that setting.
Right. Right. And then I would say, this is great, but then you also want to scale it up, right? So it isn't just the community's thing to do that work. It's then figuring out what works and pressing to scale this up to not one size fits all, but what kinds of processes can produce local solutions to shared issues that we have. Well, thank you, Denise. Yeah, thank you for that.
I'm really glad. Can you hear me now?
I can.
Good. I'm glad to see you, and really so taken by your talk and all of your work, really. You mentioned a couple of times the work that scientists, medical professionals, social scientists can do, and also humanists. And I'm in this idea of health is the work of all of us, and that we don't need to relegate it to others, just trying to think about, and would be interested in your idea about humanists and artists too, ways in which those forms of activity and scholarship and in-depth training can yield resilience and also more powerful understandings of ourselves. And I think, you know, what comes to mind to me is many of the things that we've seen during the pandemic on screens like this one, on Zoom and elsewhere. But I'm curious if you have additional thoughts or ways that we can think about that.
Yeah, absolutely. The dimensions of resilience that I highlighted, a sense of belonging, a sense of meaning, a sense of connectedness and purpose, the arts and literature. And by the arts, it sounds so fancy, right? But I mean, making spaces, humans make the spaces they live in, right? You could call that, it's survival on one level, but on another level, we're creating our life, right? And the arts can inspire people. It can give them ideas about things. It can express things that have not been expressible, that help people access stuff that is very difficult to access. It depends. The arts can act in a way like culture surgeons to go in to lance festering boils that are kind of lying underneath there, and by particularly wrapping in a form of narrative, or humans are incredibly visual, so you can put things across through narrative or visual means that have tremendous impact on humans. And as we see now in politics, of when you can also distort narrative and really mess people up with narrative. And so that's another reason that I think the arts are really important, because how do we stay straight on this? How do we do counter narratives? How do we help people cope with now what we're facing, disinformation, misinformation, but also corrosive narratives. And that's where, for a lot of us, it's racism, right? That is so embedded that we don't even see it. So I think shutting the arts out of health sciences has been a disservice to health sciences.
Right, and also thinking, we're thinking about not only just now, but going forward, and the whole idea of scaling up. You know, how do you scale something like that up? We see a lot of individual groups, individuals, companies, enterprises. I mean, there are a lot of good flourishing such associations at Emory. But how we move from a kind of individualized, atomized version of doing that, and it's just something that's it may just be kind of emergent properties as we see now, people adapting to new forms. But anyway, I'm grateful for the opportunity to start thinking about this and working with others in that way.
Yeah, I agree. I'm grateful too. Not every day. This is not easy stuff. But if we're not grateful and motivated, the opposite is not a good option. So yeah, thank you. And I wish you good luck with it. And it's so good to see you again, Rosemary.
Carol.
I think Alex is next.
Hey, Carol, thanks very much for a really interesting overview of these important issues. I'm an epidemiologist and health policy researcher, and I think one of the things that has always been interesting to me is when I think back to my whatever undergraduate intro sociology class, the basic social exchange theory is a really helpful way to understand the whole of these problems. So at its most fundamental level, and it sounds a little bit crass maybe, but if one is a baby or a toddler, you go along with your parents, you obey them, you start moving into the social norms of the family because they feed you. And so there's this exchange process at a very fundamental kind of organism level. You get fed, you get taken care of, but then you start learning the norms of that group and you adapt to your family. And you assume that you're not going to be abused, you're not going to be hit, you're not going to be neglected, and so forth. So then you get to your teens or you get to your 20s, the examples for every problem that we're all worried about, all these mental health problems and health problems, however we categorize them, in some sense, they come back to this social exchange. You're in your 20s and you have a child of your own, you're working 2 minimum wage jobs, you're trying to piece it together, and you're following all these social expectations, but society is not doing its part because you can't pay your way, and those 2 jobs don't even give you basic health insurance coverage for when your child gets sick or when you get sick, or you get no medical leave or sick leave. You know, the basic social exchanges of society. Or you were fortunate and you got to college and you graduated with your degree, but you're $100,000 in debt and you still can't kind of get it together and get it going. So across all this, we don't have this fundamental social exchange that a healthy society would have. And I think your point is really well taken. We have a laundry list of ways to fix this. These are all problems that we create in our society because we choose to have this inequality. We choose to give all the riches of society to a few people at the top. We choose not to give college to people. We choose not to give opportunities for a decent income to folks. And we can change that, and we can choose to do so and make a lot of advances. And I think your presentation nicely kind of cues that up as an agenda for us to really think about. And I think it's very relevant right now because we're dealing with this political transition. And we make these choices that have the outcomes of hundreds of thousands of people dying from COVID, hundreds of thousands dying from opioid overdoses or whatever problem you look at, gunshot wounds, car crashes, cardiovascular disease, any problem you look at. So I thank you for kind of queuing that up and bringing that to the fore for us, Carol.
Well, thank you, and I'm excited to have that an epidemiologist was along, and I look forward to what all you guys get up to and the kind of partnerships that you can forge. I mean, one word that I would add to this mix around exchange is power, right?
Yes.
That babies and their families are in power asymmetries. We're all in power asymmetries, and so choosing gets more complicated once you start thinking of power. The baby doesn't really choose to have, well, it cries and it can do stuff, but to try to get attention. But, you know, so the choices aren't always equally distributed, and that's fine some of the time, you know, but it isn't always so good. So, yeah.
Oh, that's another good point. I absolutely agree. I mean, the power dynamics are a whole part of this.
Yeah.
They're underlying the reason that it's the way it is.
Yeah. Thank you, Alex. And I think Carol Hoke is next. Carol?
I actually wanted to reflect on the last couple of three comments. Power is an extremely important issue here, and we are learning that as we deal with white fragility and white supremacy, for example, in how to turn the aircraft carrier in a different direction without the motors going and without the steerage. And I think that in this area, we have been dealing with that for a long time. I'm reminded of when several decades ago, it became kind of a cause célèbre that the United States ranked so low, like 19th or 20th among developed countries in infant mortality. And once infant mortality became there were articles written that the Black infant mortality rate was twice the white. It became their problem, not our problem, and it disappeared from the public site. My question is how to convince those in power that mental health, without mental health, you don't have health. Without racial equality, you don't have equality. That the fact that white people in this country have a lower life expectancy than white people in other countries that we can consider comparators is an indication of that, but somehow we don't seem to be able to communicate that it is our problem, everyone's problem. Do you have any suggestions about that?
Whoa. Oh, sure, I can fix that right up. Carol, you've only been working on that all your life. I think a lot of us have been working on that.
From an anthropological perspective, you know, you actually may, your thoughts are so fresh that who knows?
Well, I mean, one of the things is that I think we have to come out of the closet, out of the science closet. We are members of this society, and to find ways to act, I mean, ethically, but if I were going back to start my career again, I might go into politics and public policy. I mean, I might work on power, because it's like, hello, we know enough. I don't know about the rest of you, but it's like, we haven't learned a whole lot that's new from COVID. We've learned something about coronaviruses and stuff, and we've learned about the limitations in health sciences. But in terms of a lot of the issues there you're talking about, that's been around, and so I think figuring out the academy figuring out ways to be more engaged, to actually, and this, I know it's a huge ethical issue because on one level, you know, we're supposed to serve society, but we're supposed to critique the society. So we're kind of outside. And, but I think that outside stuff has been taken too far. And that's why elites and educated individuals are being demonized and stigmatized because they're dangerous. They're threatening to these borders of power. So I'm not sure I have a solution, except, as I say, this presentation I gave to you guys and sort of the things I've been starting to write are trying to move in that direction, or inspire those younger and smarter than me to move in that direction, and mobilize the power of health sciences. So that's the other thing. It may sound like I'm dissing the health sciences, but they're immensely powerful, and we invest so much money in them. So as you say, that there's that aircraft carrier of our society, but you know, it's loaded with the health stuff. So I'm not sure, because if telling the elites that they're worse off because they live in an unequal society doesn't get their interest, then, but again, okay, I'll end with this because I'm just rambling, I fear, but narratives are very powerful. So what I have done over my career is develop a series, you know, this whole title, Clean Water, that gets people's attention. And to build a narrative around that is compelling, that is good to think. I think these are things that we can do, is try to seize the narrative, to own the narrative, to drive the narrative, in an inclusive way. That's the hard part, right? It's like, this is good to think, and you can think about it, and you can go do something with this. It's not just something that I land on your head that, you know, shows how much smarter I am. It's about something that empowers you, and that's why the arts, literature, et cetera, that lights up people's lives, brings possibility, and you know, so narrative.
Thank you.
Keep on keeping on.
You too.
Oh, and next I think is Henry Kahn. Henry, long time.
Yes, indeed. Hi, Carol. Wonderful to see you.
Yeah.
You know, this is not the first time that you've stoked my belief that the anthropologists have the underlying problems in sight, where my field, medicine and epidemiology, is only creeping in that direction. You have clarified it. Thank you. It's a wonderful talk.
Thank you.
Let me just focus on one point you made near the end of your slides. It's not anything with which I disagree. I was delighted to see that among the steps that our society has available is the provision of universal health coverage. You know, I've believed that and worked on it for more than 30 years, and it's still true. In fact, it's now visible once again and possibly within reach. I'll get back to that in a minute. But what I really drew from your talk that I had not thought about before is that while I've believed that universal health coverage will provide to the small people who are entering a cancer diagnosis or a heart attack recently, or whatever motorcycle accident caused them to need hard medical protection,
Yeah.
that's only a small part of what we get from universal health coverage. In fact, I think universal health coverage might have a greater impact for all of us by the strengthening of our resilience. And I mean, you made some really very good points, although I would love to learn, I will learn in the next few hours what the questionnaire is by which you identified resilience. But I think it has a lot to do with empowerment, theme that we just heard from Carol Hogue, and other steps. The belief I can do this, and what universal health coverage does for everybody, not just the people who had a motorcycle accident or an unfortunate new diagnosis, but all of us. It says, I can move ahead with my career because I no longer have job lock, which is one of the consequences of not having universal health coverage. I can feel comfortable that my kids will get health care, even if I can't be there to pay for it. I have comfort that in my own dotage, there will be a healthcare and long-term care support system for me. So I have, in that sense, and everybody, including people who thought they were privileged before but may not be privileged, I have resilience as a consequence of my universal healthcare coverage. So the epidemiologists who preceded me in this response to you have raised a number of similar points. This is power. This is power. And I think we should take advantage of that. And all of us on this call, at least those of us who live within voting distance of Atlanta, Georgia, need to know that this afternoon, the Atlanta City Council will have the opportunity. I can't be sure they will take it. They have the opportunity to pass yes on a resolution endorsing the global policy of universal health care.
Whoa, I didn't know that.
We've worked on it for almost a year to push it through Atlanta City Council, and we all know that Atlanta City Council will not implement universal health care, but they will join 42 other cities in this country that have already passed municipal resolutions saying our city needs universal health care. They didn't use the word resilience, but I think we should slip it into the next framing of this very important but yet only one of many steps we can take toward the mental health and the societal health, which you have so beautifully endorsed. Thanks, I really appreciate your talk.
Well, thank you, Henry. And actually, your elaborations on resilience made me think of one other thing, which is the US healthcare system is massively inefficient. I mean, if this were a corporation, they would have been long since bust and nobody would buy the stock, because the input of money and resources in relation to the quality of the output is horrible. And there are lots of reasons. Again, it's not the providers, it's the system. And so just think if we could liberate those resources. What could we do? We might have better infrastructure. We might have good schools and pay our teachers better. And, so I think it only just dawned on me that increasing the efficiencies in the healthcare system by universalizing it would actually, big pharma and everybody else would fight it like crazy, but ultimately everybody would benefit.
Well, certainly that it really pushes up against the related point of income support. The people who think they have good health coverage now because their employer provides it don't really recognize that the premium their employer contributes to the plan is not free. That premium comes at the expense of higher wages or of longer vacations or better working conditions. If it were no longer necessary for the premium to be contributed by the employer of the superior private health plan, then it would gently nudge up the salary and the satisfaction and the working conditions for all of us who have generous employer plans.
Right. Yeah, that's for those of you who haven't looked at Case and Deaton's book this year. That's one of the arguments that they make in great detail. So that's a great point, Henry. Thank you.
Thanks.
And we'll try to make time. There are two more people, so let's see if we can keep going. I think trying to find Elsie, or I can't. WR Elsie. Is that you?
Maybe.
Hello.
Yeah. Can you hear me?
I can.
Oh, okay, great. Thank you so much for great ideas and a great talk. I'm another one of these old physician epidemiologists, and of course I completely agree with Henry Kahn that I love. Some 20 years ago or so, when I was head of the Fulton County Health Department, a couple of extra points to suggest. One of the things we did was study years of life lost to analyze those. and are quite different often than the major causes of mortality. In Fulton County, we found the greatest cause was injuries, including accidents, suicides, and homicides. So there we go. Now, one of the ways we had to deal with that, fortunately at the time, in our health department, we also had the job of running the public mental health services, which were about 40% of our budget, something like that. So it was a great way to try and put things together.
Yeah.
Of course, one of the greatest causes of all of these years of life lost was addiction, drug abuse. And so I was pleased that we had a major drug treatment hospital at the time, which could be very helpful.
Yeah.
So that's mainly what I had to say. Thank you so much for a great talk.
Yeah, well, and you probably know, you know, the government is not allowed to collect data on firearm injuries. Has that been changed? I thought there was some idea.
It's changed a little bit. I think you can do a little bit with restrictions.
Yeah. So, I mean, that's the other thing that we're struggling with is actually having good enough data. I mean, right now, you know, nobody in the world trusts the data that comes out of the CDC. They'll only look at what Johns Hopkins is doing, which is pretty sad, right, in terms of public goods. Yeah. So, wow, thank you for sharing that background. I had no idea.
Thank you.
Great. Well, I think we have one more person, and that's Spencer King.
I'm not an epidemiologist, so there.
Good.
But you're right. CDC is prohibited from doing, you know, collecting data on gun violence. That's a specific prohibition. My only question and comment is, with the tribes that we've developed, you've laid out the problems extremely well, but it seems to me that we can't get over the idea that public health is a collective effort. I'm including universal health care as part of public health. I'm including everything you talked about that influences our disability adjusted life years in this country compared to other countries. So the question I have is sort of the one Jimmy Carter had when he came out of office. He came to Emory, I remember very clearly, and he gave this talk. And he said, now you people at Emory are very smart. You figured out a lot of things about healthcare and disease and all this kind of thing, and how to treat and how to operate on people. Why don't you just quit all that? You know a lot. Why don't you apply it? Why don't you actually make it work somehow? And I'm sort of struck. I think you should have run for office and take this. I think the power is where it is. I think somehow we've got to convince people. People can be convinced, they should be convinced that public health is good for them, that healthcare is good for them. But the tribes that we've created make it a knee-jerk reaction now that there's a strong political force that says, if it's, you know, if it sounds like public health, it sounds like socialism. And therefore, I'm against it, regardless of the fact that I don't have any health insurance, regardless of the fact that my life expectancy is short. Forget it. I'm just on the other team.
Yeah.
So, you know, short of people, you know, enough people, the majority of not people, but the majority of electoral votes getting to that point, and I don't know how we get there. Somehow we got to convince people that individualism is fine, but it's not public health. That's the only point I want to make.
Yeah.
Where you headed? Where you been?
Yeah, well, the weaponization of culture is something that politicians have always tried to use as a strategy, but it's become particularly
It's working.
I would say, because we have new means for communication. And so social media have been demonized in a variety of ways, but I see this also as a culture issue. I tried to imagine, I haven't found a book, I bet there is a really cool analysis of what happened in Europe when books became widely printed and available. And people started to learn to read and stuff like that. It's like, this isn't the first time in human history that there have been breakthroughs. Like, what happened when people learned to start talking? I mean, I don't know, or writing. So what we're dealing with in part is a convergence of things that include massive culture disruptors, because social media can be fantastic, but they can also be very problematic, and they're new, and we don't have good cultural norms and adjustments to them. And the problem is culture can change amazingly fast, and yet it can also be pretty slow to change some of the big stuff. And we're having real trouble catching up in terms of how and we don't seem to have the time in some ways to catch up with these disruptors that are coming into culture processes. And here again, I would say that's partly why you really need those culture analysts, but people also who are masters of narrative and decoding narrative, so that we can try to sort of start building tools to work in this new framework that we're dealing with. You're absolutely right. This is, it looks as though it's runaway. In that regard, I would point to a really interesting book on a Highland New Guinea society by Gregory Bateson, where he talked about schismogenesis and how cultures can get into this kind of spiral that you're talking about. And now what I'm thinking about is I need to go back to that book. I'm even forgetting the title. I got to go back to that book and see how they got out of it, because the society existed. didn't knock themselves out. So how do these spirals happen? We see that now, but you're asking, how do we get out of this? How do we work with that?
Yeah, so Sapolsky's book on behave is one of my favorites. And the idea that, you can weaponize, I mean, you can, the Hutu and the Tutsi and that whole thing. And we've done a job with that. And I don't know how people can get where they can talk to each other again and say, well, wait a minute, if you take some epidemiologists, I think, looked at took a vote about what kind of healthcare people would like, and without identifying them, they put certain systems together, and Americans voted for a Swedish system, not knowing it was Swedish. So how do you get people, to even look at something that the politicians have convinced them is just not on their team? That's Georgia Tech. That's not Georgia. You can't be for them somehow. Anyway, that's too much for me, but I enjoyed it very much. I think
Thank
made
you.
me think a lot about this.
Well, I think I, for one, maybe all of us have been humbled. That question of how we talk across differences, I have been saying for years, is actually the great challenge of our age. That and learning to live with less, live well with less, are the two great challenges of our age. And yeah, well, we're still working on it. So I see that we're up to time, and I know that some of you want to chat and hang out with each other. You see each other on a regular basis, and others of you need to go. So I want to thank all of you for being here at this time and for sharing your thoughts. And I wish you wellness in body and mind. So, ciao.